Well, good morning, everybody, and thank you for that very warm welcome. Thank you for all of you on a Sunday morning to be here. Yes, it is a bit of a shame. Some of our adult cardiologists are not here to listen. I found yesterday's session to be very valuable because there's so much that they do systematically due to the number of patients they have and certainly less complexity as well. But there's a lot, I think, that could be shared with us and much that we can learn. So, again, very honored to be here and to share ideas and some concepts and thoughts with you. There's going to be a lot less data from what I have, much of it opinion, and I think open to discussion, and hope that we can have a good exchange and a vigorous exchange. When I first saw the title to this symposium, I was very encouraged looking at this tremendous title, New Valve, New Power. And I had heard of the conference even before I got invited. I said, well, this is a great title to use. And then I saw my particular title, and I said, what does a Fontan circulation have anything to do with a valve conference? And then it was interesting, literally the same week that I got the invitation, my wife sent me this picture. She was shopping in a supermarket locally, and in aisle 32, she said, can you believe they put these three things together? I said, why do these things go together? So, I looked at this and said, well, maybe Felix and others are thinking about this conference in the same way. There's something subtle about things that go together. I don't know if any of these go together. They don't at all. But I am going to review with you the concept of the valve, defining what a valve does in cardiovascular physiology, and its relevance to single ventricle and the Fontan circulation. So the question is this valveless circulation a valid one? And I think the answer is yes. It is a valid option. However, it is also wishful thinking to think that it's a perfect solution. It is not. And part of this is that we need to modify our expectations about what we are doing for our patients with single ventricle, and therefore also motivate us to continue to improve our thinking, to continue to improve the options for these patients. Now, why do I say this is valid despite all the realization of the limitations of this? It's because we don't have many limited alternatives, and I think we need to look at the history of what we've been able to offer these particular patients. And there's nothing more that does this than this particular paper that came out in 2020 from the group that has really provided us with a lot of interesting information. It's the Australia-New Zealand Fontan Registry. And in this one of many, many papers that they've published from this particular group, looked at Fontan patients, over 800 Fontan patients over the age of 16, and stratified them based on having high risk or low risk. And if they had any of these risk factors, they were high risk. Only about 25% had high risk over the age of 16. The majority, the vast majority, didn't have any of these risk factors. Then they took specialists in actuarial science, which I still don't understand. That's predicting the future, being an actuarian, but there is a profession of actuarians who calculate life insurance and life outcomes and such. And they use that actuarial science to model survival estimates for patients who were over the age of 16 without these risk factors. Again, the majority of patients, into pessimistic, conservative, or optimistic projections. And the projection was that up to 60%, perhaps even as high as 80% of our patients over the age of 16 with a Fontan will be alive at the age of 60. That is profound, I think, and that is something that I think our community needs to congratulate itself for. We've taken a lethal condition, a birth defect of the heart, that 40, 50 years ago, you know, when Fontan was working on this and others were thinking about it, could only dream that we could have this potential outcome. I look at this as a positive thing. So this is a viable option. It does not mean that we still don't have a lot of work to do. We do, but it is viable. And the question to ask is, why is there so much variability in outcomes? Why is it that many of our adult cardiologists, some of you in the audience here, will see a 25-year-old Fontan patient? I saw one just last week, and you cannot tell the difference. It's shocking how well they are, going to college and functioning well and exercising, which is key. But yet, there are 6-year-olds, 10-year-olds with PLE and others that are failing. And why such variability is a question I think we need to ask and begin to answer. We don't have the answers to it. So we have to go back to the origins of this entire concept. And it was from the Fontan and Baudet paper in 1971 where this quote is taken. And it was prescient, it was predictive of where we are today. Quote, "This procedure is not an anatomical correction, which would require the creation of a right ventricle, but a procedure of physiological pulmonary blood flow restoration with suppression of right and left blood flow mixing. The objective of the Fontan operation initially was to treat cyanosis, because patients were becoming cyanosed. They would get a shunt, they would get another shunt, they would get another shunt, and then ultimately succumb to the condition itself, either hypoxia or these multiple operations. This was a way to create some sustained state that would treat the cyanosis. However, now that we have gotten to this level, the question is, what price do we pay for the suppression of mixing and increased arterial saturation? But notice, in Fontan's original paper, of course, there are 2 valves that were put into the venous system, with the idea here being that we could utilize the right atrium to replace the missing right ventricle as a pump, and therefore utilize the concepts of valves into and out of that pump to help create efficiency in blood flow. And then the thinking shifted, thanks to Marc de Laval, who unfortunately, as we know, passed this past year. He passed away. And he delivered the concept of the total caval-pulmonary connection, shifting away from the idea of a pulsatile sense of flow to trying to streamline flow into the Fontan circuit. What can we do to reduce the energy losses that are present and do everything we can to accommodate that passive venous flow into the system? And that's where we are today with that concept. It's a valveless circulation where we do everything we can to streamline the flow in a passive manner. And what does that result in? No matter how good the Fontan is, no matter how effective and great the candidate is, every one of the patients has these characteristics. My computer has frozen. Here we go. Okay. So, central venous hypertension, common in every one of the patients. Low cardiac output due to an impaired ability to deliver a normal quantity of blood volume across the pulmonary bed, impaired ventricular filling and low stroke volume, inability to adequately increase the stroke volume during periods of increased demand, and impaired chronotropy. These 4 principles exist in every Fontan patient. And where are we with the clinical consequence of this? If we look at any 25-year outcome of any large study, the Australia-New Zealand study, the Mayo Clinic, Boston Children's Hospital, Philadelphia, my own center, and anywhere around the world, these are the findings. It's about an 80% survival 25 years out after the Fontan from a mortality perspective. However, very few patients are going to be morbid-free. And it appears that in the adolescent years is when we begin to see that decline with end organ dysfunctions. And what are those specific dysfunctions? There's a signature to the clinical scenario that we see. One could almost call this a Fontan circulatory syndrome. There's a chronic state of increased central venous pressure and low cardiac output, and a variety of elements of what could be referred to as biological dysregulation. And I do think that we do deserve to dig a little bit more deeply into the biology of this particular circulation to better understand some of the end organ consequences. We see lymphatic system stress and congestion, which in about 5 to 10% of patients leads to protein spillage, either plastic bronchitis or protein-losing enteropathy. But every one of these individuals does have some degree of lymphatic stress. Liver fibrosis, universal in all of these patients. Poor growth and bone health deficiencies, coagulopathy, exercise intolerance as a consequence of the cardiovascular system, but also other elements of other organs. Neurodevelopmental deficits and learning challenges, and very commonly now in probably close to 3/4 of patients, clinically important anxiety, depression, and mental health challenges. This is the signature of how these patients are landing into their adult years. Now, one particular complication is attracting a fair amount of attention and is becoming more and more characterized as we follow these patients into their adult years, and that's the aspect of Fontan-associated liver disease. And one could ask the question that perhaps, is this one of the more likely complications related to some degree of congestion, venous congestion and venous hypertension, and therefore perhaps most amenable to a response in lowering venous pressure? It's an interesting question. I'm not sure that that's fully explainable by venous hypertension, but it is something to think about. We do see this phenomenon in all of our patients. There are no Fontan patients who don't have some degree of liver fibrosis. And we and others have explored this in a number of different ways, controversial, but we have a policy at our institution where when you are 10 years out after your Fontan operation, we are performing a routine surveillance cardiac catheterization and a liver biopsy. Again, with limitations and controversy to it, but this is what we've collectively agreed to as an institution. And we perform what we call our liver fibrosis assessment using serious red staining, which is a way to look at the total amount of collagen deposition in a particular sample from the liver. And we thought this would be helpful to stratify where our patients are as they enter their adolescent years. Again, 10 years out, so typically these patients are about age 12 to 14 years of age. And to see if there might be other biomarkers that may reflect these particular changes. We have not found anything that was significantly associated in now close to maybe about 250 biopsies that we've performed. We published our first data looking at our first 90 patients. But what we did find, with a fair amount of scatter, but still significant, was an association between the magnitude of hepatic fibrosis and simply age alone. So it's not the hemodynamics, it's not any particular historical feature, it's not having a single right or single left ventricle, but simply the clock, number of years that you have a Fontan circulation is associated with the magnitude of liver fibrosis that you have. So this is somewhat concerning as our patients enter their adult years. So without going through bioengineering or physics or formulas or such, in a very simplistic, from a pediatric cardiologist hemodynamic perspective, what is the purpose of a valve? We've been talking about valves the past 24, and we'll be doing it today as well. I haven't yet heard an explanation of why we have valves. What do valves do in the cardiovascular system? In a very simplistic way, this is how I think of it. You have a pulsatile state, you have chamber A, chamber B, and a valve between the two. And if you deliver flow into chamber A and that valve is open, that flow gets into chamber B. But when the valve is closed in diastole, you have the ability to maintain a higher pressure in the downstream chamber relative to the proximal chamber. That's the purpose of the door, the valve, to keep a higher pressure downstream. So think of the pulmonary valve, the aortic valve. You're maintaining a higher pressure in the pulmonary artery than you are in the right ventricle, higher pressure in the aorta than you are in the left ventricle, in diastole. But when you have a non-pulsatile state, what purpose does a valve serve? Well, it might help in creating unidirectional flow and keeping the flow going forward. But without that pulsatility, without driving something forward, the valve could potentially diminish the flow in chamber B if it acts as a resistor in the system. Now, you might think there are no valves at all in the Fontan circulation in the venous side, but there are. There are venous valves. And the purpose of the natural presence of venous valves are to prevent stasis and pooling. And they do so when there are normal conditions. However, if you strain your venous system, either with progressive aging that happens in some of us in our lower extremity, or in a Fontan circulation, you can create dysregulation and dysfunction of those venous valves. So let me shift here for a moment as I was thinking about the connection between valves and a Fontan circulation. There may be another valve that plays an important role here. And I'll talk to you in a moment about what that valve is. But the thinking about this comes from a question from a patient. I do my due diligence. I have a fantastic team of people where every time we see a Fontan patient in our clinic, we do education. And there's a great need for education. Most of our patients and families still don't have a good understanding of what's going on here. And I speak to the child and I'll tell them what's going on. They don't have this pump. And I had a good question once from Ryan who said, wait a minute, if there's no pump, how does the blood get there? Which I thought was a profound question, because if we stop for a minute, I'm not sure we have a clear answer for that in our Fontan patients. William Harvey correctly described the circulation back in the 1600s, and he defined a normal circulation as having a right side and a left side. The veins travel to the heart, arteries travel away from the heart. We don't have a right ventricle in our single ventricle patients. So what are the determinants of blood flow in a Fontan circulation? And what of those determinants is the most powerful determinant in driving blood when you don't have a right ventricle? It's a very fundamental question, and I'm not sure we've clearly answered it. So let me give you my idea, my concepts on this. And so if you think about it, what drives blood? I'm standing here right now, and I have a right ventricle, but even those of us who have a right ventricle, our peripheral musculature is contracting to drive venous blood forward. So your peripheral musculature contributes. Your intravascular volume is important. Your venous capacitance and tone. The nature of the Fontan circuit pathway is important. Right? That was the de Laval concepts of making sure we have streamlined flow. These are the extrinsic features, if you will. Then there's, within the chest itself, the thoracic cage musculature, the pulmonary vasculature, endothelial function within the pulmonary vasculature, and then the heart itself, the cardiac rhythm, ventricular diastole, and ventricular systole. I'm sure there are probably one or two that I'm missing that you could think of, but these are the major determinants that I think of when we are talking about what drives blood in a patient with a Fontan circulation. And now, where are we focusing our attention? There's a lot of attention on pulmonary vasodilators. Can we reduce the impedance to flow forward? That might make a difference in our patients. A lot of interest in ventricular diastole. Some of the early papers from Andrew Reddington and Daniel Penny in the 1990s looking at relaxation of the ventricle as a receptacle. That's an important feature. Not too much that we can control there, not too much that we can modify. What might be modifiable, a lot of new interest, is in the thoracic cage musculature and in the peripheral musculature. In other words, if we improve diaphragmatic function and improve peripheral musculature, might we drive blood more effectively when we have a Fontan circulation? And then there is ventricular systole. And this is what I want to propose to you, that of all these factors, we don't know what the ratio is between them, that ventricular systole may in fact play a much more important role than we think in driving blood when you have a Fontan. And this derives from an old paper that we did actually in Philadelphia back in the 1990s, simply looking at Doppler flow characteristics in our patients with single ventricle. We are performing echoes every day on these patients. Take a look at the pulmonary vein flow patterns in your single ventricle patients. And this was a study where we looked at patients and their pulmonary vein Dopplers as they went from a shunted state to a caval pulmonary state, either a Glenn or a Fontan. Pulmonary vein. This is the pattern that you see here. My arrow's showing up. So you have systolic flow and diastolic flow, QRS. And this is what the pulmonary vein Doppler looks like after we've gone from a shunted state to a Glenn. The dominance of flow is in ventricular systole in the pulmonary vein. If you do an S to D velocity time integral ratio, in fact, it's after the Glenn that the proportion of systolic flow actually goes up in the pulmonary vein. So what is this telling us? There's an increased proportion of pulmonary venous return that's shifted to systole after a caval pulmonary operation. What causes that systolic flow? There's no pump. There's no right ventricle pushing blood forward. So why is there a systolic waveform in the pulmonary vein in a patient with a Glenn? And here's some additional information doing TEE, looking at the pulmonary veins and superior vena cava. So we've taken respiration out of the picture here. Patients are intubated. And we were able to nearly simultaneously perform pulmonary vein and SVC Doppler sampling. So if you just draw a line through the QRS, these are two beats that are nearly simultaneous. Pulmonary vein systolic waveform is bigger than a diastolic waveform. And in fact, when we look at the superior vena cava flow, there's more flow in systole. This is a delayed systolic waveform. So let me propose to you that ventricular systole plays an important role. And what is it within ventricular systole? It's atrioventricular valve descent towards the apex. It's valve function that is expanding the atrium and causing an aspiration of blood through the pulmonary veins. Not too much work's been done in this area, particularly in the Fontan patients, but this is just one study looking at normal athletes. Atrial filling during ventricular diastole was only 30% of the total stroke volume, while in ventricular systole, it was 70% of stroke volume. So AV valve descent towards the apex of the ventricle expands the atrium, draws blood forward in the pulmonary vein, and is the pump for your Fontan circulation, drawing blood forward through the pulmonary circuit. So if you take this concept into our patients, say with tricuspid atresia, single left ventricle, they may have a bit more efficient AV valve descent. Now take our patients with HLHS and a single right ventricle. Look at how blood gets drawn into the ventricle. You may have an abnormal tricuspid valve, a right ventricle perhaps, that's not as efficient in its contractility as the left ventricle. Your AV valve descent is not as efficient. You don't draw blood forward as well. Your pump is not as efficient as it is. And this is a little bit of a shift in concept. We think about ventricles as systolic driving blood forward pumps, but in our Fontan, it may be a pump that's sucking blood forward as well. We need to think about that from its efficiency perspective. So what work has been done in this is a little bit of work. Atrial function has been studied in a small number of patients using CT. This particular study from Japan did find better atrial function was associated with higher cardiac output and freedom from Fontan failure. And then a multi-center study with nearly 100 patients using MRI and atrial function using volume time curves. This particular study did not find that atrial function was correlated to exercise or follow-up events. These are the only two studies I could find on this, but it does give us the sense that more evaluation is worthwhile. And finally, we're going to get a talk, I think, later this morning on the concept of revisiting putting a valve into the Fontan circuit. But what currently exists already on this? Two pieces of work that I could find. Why might you consider putting a valve into a Fontan circuit? Well, if you might lower upstream pressure or if you could diminish retrograde flow and maintain ventricular downstream preload, it might be something that could be beneficial. So one is an engineering computational study from Ajit Yoganathan in Georgia and their work, and he did some in vitro experiments in a TCPC and found that by inserting a bovine venous valve, valve closure could be achieved in about 20% of the time with a reduction in upstream pressure by about 5 millimeters of mercury. problem with this particular study was it does not fully recreate what truly exists in a Fontan. And in order to generate this drop in 5 millimeters of pressure, they actually had to create pressure fluctuations, which they said were to mimic venous pulsations. But there are really very minimal pressure fluctuations in a real Fontan circuit. So this is extremely theoretical. Another study that I found was quite interesting, and again, I have to tell you that I've had no experience, nor am I aware in the US of any experience of putting any pulmonary valves in, but there's a French group that did do this in 4 patients with a failing Fontan circuit, 2 with PLE, 1 with severe edema and ascites, 1 with lower limb venous insufficiency. And they measured pressures this was a Melody valve inserted into the Fontan conduit through catheter techniques, the Melody valve being a bovine venous valve and perhaps more amenable, more sensitive to low pressure flow and such. A fascinating concept and worthwhile attempt. They found no pressure differences were created. However, they did get some clinical improvement in 1 patient with treatment of PLE for over a 2-year period of time. What is interesting as well is that when they imaged these valves in 2 out of 4 of these individuals, they did not see any valve movement at all. So still hard to know whether this was valuable in any way in this particular circuit. So the Fontan circulation is a valveless circuit, perhaps. Valves do play an important role, as I've demonstrated to you. First answer to the question, I think the Fontan is a solution that provides a pathway for survival, but it's still markedly suboptimal. We need a lot more work to do to think about how to improve this. Let me suggest to you that systemic AV valve performance and its dynamics strongly influence Fontan circulatory status and is something we need to study a bit more effectively. And the question of whether inserting venous valves make a difference in the circulation, I still think is an open one, but on theoretical grounds, I question its particular value in this circumstance. So once again, thank you so much, Felix, and to the organizing committee for inviting me, and look forward to our next set of talks.
Thank you very much, Jack. Brilliant talk. May I just address one question? With this sucking mechanism of the atrium, with ongoing age in this population, you have a failing of atrial function as well, but also accompanied with a diastolic dysfunction of the ventricle. So in any way, this is an underfilling. It's probably a problem of an underfilling of the pumping systemic ventricle. What do you think is most important, atrial function or diastolic dysfunction?
Yeah, you've nicely outlined what I think is a complex interplay between all of those features. I don't think you can separate any one from the other. So atrial function is a factor of ventricular performance from the AV valve descent perspective, as well as the diastolic compliance aspects. And then there's a secondary element of what itself is happening to the atrium. This sort of image that I provided you earlier of a combined atrium, small left atrium, right atrium, when you have HLHS, is an altered atrial capacity as well. So it's hard to distinguish the two. I think it's going to be very hard, at least with the work that's been done so far. And to quote de Laval, we have significant ignorance, I think, in this particular area. What I will say, however, is you did mention the end result of the atrial and atrial compliance, atrial function, and ventricular compliance issue is the preload concept. And something else that we can do also contributes to preload, and I did not mention it in my talk, and that's the presence of a fenestration. And this is where I think there is a role to consider in select patients, again, it relates to the incredible variability of this entire population. In select patients, fenestration is a very effective way to overcome some of these elements of atrial dysfunction and particularly ventricular noncompliance. Not in all. The other thing to mention in this complex interplay is that for effective atrial function to be most contributory to the circulation, you have to have some of the other elements in good condition as well. So going back to what is upstream is the pulmonary circulation. And we focus a lot on that. It's certainly important. We're targeting medications towards lowering pulmonary vascular impedance and such. If you have a healthy vascular impedance, then downstream, having a good aspiration, a good sucking mechanism, creates the most effective Fontan. But if you have a good downstream aspiration, but your pulmonary vasculature is abnormal, you can suck as much as you want, you're not going to drive blood forward. So I think what we're getting at is that there's a sort of a perspective and a complex interplay of some variables that perhaps we haven't focused attention on. I'm not sure how modifiable they are, right? I don't know what we can do to improve atrial function, but perhaps thinking about it from the a priori, from the get-go, when we design our strategies for care, we might want to think about how we can best optimize atrial function. But there is more work that needs to be done.
Thank you very much, Jim.